Tomorrow's metabolic medicine deserves a story that is as bold as the science. Today, from Varanasi and the Cardiabcon Society, this is that story. From Varanasi to the world. Namaskar. I am Dr. Ashutosh Mishra, from Panacea Hospital and the Cardiabcon Society of Cardio-Diabetes and Renal Disease in Varanasi, India. Today I want to take you on a 10-minute journey into the future of metabolic medicine, triple threat, triple benefit. The rise of GLP-1, GCG, FGF21 Triagonists in tomorrow's metabolic medicine. Varanasi is one of the oldest living cities on earth, but the diseases walking into our OPDs are painfully modern: type 2 diabetes at 30, triglycerides above 800 mg per deciliter, fatty liver in teenagers, and myocardial infarction in the early 40s. Cardiabcon was created to respond to exactly this cardio-diabetes-renal convergence, and this is why Triagonist therapy is not just exciting, it is necessary. The Cardiabcon patient. A living case. Imagine a typical Cardiabcon patient. He is 42 years old from Eastern Up, BMI 27, central obesity, triglycerides 900 mg per deciliter, non-HDL cholesterol high, ultrasound showing MASLD, HbA1c 8.2%, father died of an early MI. He already takes metformin, a statin, a fibrate, omega-3, maybe a GLP-1 agonist if he can afford it, yet his triglycerides remain in the pancreatitis zone and his liver is silently marching towards fibrosis. For this patient, the traditional, sequential, one drug, one target model is failing. The problem is not one number, it is a tangled metabolic web: glucose, triglycerides, liver fat, inflammation, visceral adiposity, all feeding each other. What if instead of adding the fifth and sixth pill, we could press a multi-system reset button once a week? 3 hormones, 1 purpose. To answer that, let us briefly revisit 3 familiar hormones. GLP-1, the hero of the last decade, boosts glucose-dependent insulin secretion, slows gastric emptying. 1 purpose. To answer that, let us briefly revisit 3 familiar hormones. GLP-1, the hero of the last decade, boosts glucose-dependent insulin secretion, slows gastric emptying, and powerfully reduces appetite, leading to HbA1c reduction, weight loss, and cardiovascular benefit. Glucagon, once feared only as a hyperglycemic hormone, in the right dose becomes a potent driver of hepatic fatty acid oxidation and energy expenditure, increasing basal metabolic rate and enhancing fat loss. FGF21, the newer player, is a stress-induced hepatokine that promotes fat oxidation, improves insulin sensitivity in muscle and adipose tissue, reduces hepatic steatosis, and has anti-inflammatory and antifibrotic effects, particularly relevant for MASLD and MASH. Dual agonist studies. GLP-1 plus GCG, GLP-1 plus FGF21, already show that combining pathways produces effects greater than the sum of each alone, especially on weight, liver fat, and lipids. From addition to synergy, the triagonist concept. Triagonists like GLP-1, GCG, FGF21 are not 3 injections in one syringe, they are single molecules engineered so that the 3 signals work in synergy. GLP-1 reigns in glucagon-induced glucose output, while preserving its thermogenic and lipolytic benefits. FGF21 clears liver fat and improves insulin sensitivity, amplifying the impact of weight loss and lipid mobilization. In clinical terms, this means one weekly agent can pull triglycerides down, both fasting and postprandial. Drain fat out of the liver and visceral depots. Improve non-HDL cholesterol and triglyceride-rich lipoproteins. Reduce HbA1c and weight, while calming chronic inflammation. In other words, this is pharmacologic, virtual bariatric surgery, focused on the liver, pancreas, adipose, brain axis. The metabolic domino effect. The most advanced example of this concept today is DR10624, a first-in-class triple agonist targeting FGF21, glucagon, and GLP-1 receptors with a convenient weekly subcutaneous dose. In a Phase 2 randomized trial presented at AHA 2025, adults with severe hypertriglyceridemia, median baseline around 830 mg per deciliter, many with diabetes and fatty liver, received DR10624 at different doses or placebo for 12 weeks. The primary endpoint was fasting triglyceride reduction, and the results were striking, median reductions of about 74.5% with 12.5 mg, 66 to 69% with higher doses, versus roughly 8% with placebo, with nearly 90% of treated patients achieving triglycerides below 500 mg per deciliter. MRI-based liver assessments showed rapid, large reductions in hepatic fat, and there were parallel improvements in non-HDL cholesterol, triglyceride-rich lipoprotein cholesterol, and other atherogenic lipids. An integrated reshaping of the cardiometabolic profile. Safety, tolerability, and real-world feel. What about safety? Over 12 weeks, DR10624 was generally well tolerated, with the most common adverse events being mild gastrointestinal symptoms and injection site reactions, familiar to anyone who uses GLP-1 receptor agonists in clinic. Importantly, no clear signal emerged for increased pancreatitis, severe hypoglycemia, or major organ toxicity in this short-term study, although longer observation is clearly needed. For glycemia and weight, even in this lipid-focused population, DR10624 showed improvements in HbA1c and modest weight loss, consistent with its incretin and glucagon actions. So we are not just rescuing triglycerides, we are also quietly helping the diabetes and obesity that drive MASLD and cardiovascular Asian lens. Why does this matter so much in Varanasi, in Delhi, in Dhaka, in Lahore? Because MASLD and triple dyslipidemia are exploding across South Asia, with India showing some of the fastest growth in fatty liver burden globally. The young South Asian phenotype central obesity, high triglycerides and non-HDL cholesterol, elevated ApoB, modest BMI, and early diabetes, is exquisitely vulnerable to premature ASCVD and pancreatitis. Cardiabcon's vision, from its inception, has been to expand horizons in cardiology, diabetes, and renal disease, not to treat them in isolation. A therapy that can simultaneously address triglyceride-driven pancreatitis risk, fatty liver progression, and cardiometabolic risk factors in a single weekly injection fits exactly into this integrative vision. Which patients should we think of? How might a Cardiabcon clinician or any clinician worldwide identify candidates if a triagonist like DR10624 becomes available? Key archetypes include 1. Patients with persistent triglycerides above 500 mg per deciliter despite optimized statin, fibrate, and omega-3 therapy, especially those with prior or impending pancreatitis. 2. Individuals with MASLD or MASH on imaging or biopsy, particularly when coupled with high triglycerides or mixed dyslipidemia and early diabetes. 3. South Asian patients with discordantly high non-HDL cholesterol or ApoB, mild CKD, and clustering of cardiorenal metabolic risk factors. For these patients, the potential to replace multiple oral agents with one integrated, once-weekly therapy is not just elegant, it could transform adherence and outcomes in crowded, resource-limited clinics from Varanasi to Lagos to Lima. A call to the global community. Of course, we must be scientifically disciplined. Phase 3 trials, long-term cardiovascular and renal outcomes, pancreatitis prevention data, and head-to-head comparisons with existing regimens are all needed before routine use. Questions remain about durability of effect, rare adverse events, interactions with SGLT2 inhibitors and emerging MASLD drugs, and cost-effectiveness in low- and middle-income countries. Yet the direction of travel is clear. Global data show that MASLD, hypertriglyceridemia, and diabetes are rising fastest in precisely those regions with the least capacity to absorb chronic complications. Multi-pathway agents like GLP-1, GCG, FGF21 Triagonists offer a realistic chance to not only control numbers, but to bend the trajectory of fatty liver, pancreatitis, and cardiovascular disease at scale. The Cardiabcon Challenge. So, From the Ghats of Varanasi to clinics across the world, the message today is simple: our patients bring us triple threats: diabetes, dyslipidemia, and fatty liver. It is time we respond with triple benefits. GLP-1, GCG, FGF21 Triagonists like DR10624 embody a new philosophy: treat the network, not the node, treat the person, not the single lab value. To every clinician watching from cardiology, diabetology, hepatology, nephrology, and primary care, the invitation from the Cardiabcon Society is to engage with this science early, join trials, contribute real-world data, and help design guidelines that make these therapies accessible, ethical, and equitable. If we succeed, the next decade of metabolic medicine may be remembered as the era when we finally matched the complexity of cardio-diabetes-renal disease with therapies powerful enough to change the story here in Varanasi, and across the globe.